How is it September? It's crazy.
Well, let's get started. If a few more folks are in, no problem. Welcome to our webinar for this month. For those of you who haven't met her yet, she's wonderful. She is our pelvic floor physiotherapist here at Pelvic Care. She works virtually with us, but she's here to explain to you how that can work as well. I know some of you have been a little bit skeptical about virtual care, so I think it's just easier if you meet her in person and get to know her. And she's going to talk a lot today about postnatal pelvic health, and I'll let her take it away.
Yeah, I'm super excited. Thank you so much for taking your lunch to spend it with us. Whether you're an expecting mom, a mother, a partner, or friend, or you just recently delivered, hopefully you can take away something from today's session. And we'll be taking some questions, just like if you do have questions during, I just explained how I can't really see the chat right now and I'm too scared to mess anything up from my setup. So Jillian will just shout them out to me, or we can save them for the end. So a little bit about me. Yes, it's a virtual physio, so I'll explain how that works a little bit, but I find that it works really, really well. And specifically for pelvic physio, it kind of gives you the sense of taking control over your own body, which I think is really great. And why I got into pelvic health is because it completely changed my life. So previously I was a professional athlete and I was a libero for Team Canada and I played. And we used to laugh about how we'd leak during warm-ups and practices. And we're like, oh yeah, it's so funny. Of course, now I'm that was totally not normal and totally you can fix it. And so it completely changed my life. I find it very empowering. And now my main goal is just helping as many people as possible. Recently in my practice, I found a huge gap basically from postnatal to returning back to things you love and back to activity. So that's really where I've put a lot of my efforts. If you had a knee surgery, you'd literally be given a prescription for physio and then they'd be go take care of this, strengthen, do all these things. You birth a child and I'm cool, see you in 6 weeks and you'll be all good. And I'm no, there's so many other things. So even if it's most recent or you're a little bit past that, it's years or decades later, there's still so much we can do. And I'm really excited. Obviously, I get way too excited about this. And then currently, I am now focusing on marathon and triathlon training. And a little bit of a fun fact, I'm hoping to complete a full Ironman in the next month. But enough about me, this is about you. I would love to know who has ever been to a pelvic physio before. So maybe if you can just write in the chat if you have or not, and then Jillian, maybe you can tell me what they say. Oh, I can see it. Oh, thank God. Okay, no. Okay, great. So hopefully also thank you for putting stuff in the chat because now I was able to bring it open. So fantastic. So no, you haven't. And I'm assuming maybe you've never even really heard of it before. Is that true? You guys have never heard of pelvic physio? No? Okay, great. So let's get into kind of what it's all about, why you're here. And I do a lot of prenatal, but this is going to be all about postnatal pelvic physio. This is just a little bit of a breakdown of when I would see people, but honestly, I see people even before 4 weeks. I see almost 2 weeks now virtually. Great. I can't wait for you to learn all about it today. So objectives of today are going to be just learning, okay, first of all, what the heck is the pelvic floor? Because it's things that we've never learned about. And whenever I go over the anatomy, it's very eye-opening, I find. What the main roles of it are, common findings that I see and common conditions I treat postpartum, and then of course where pelvic floor rehab fits in. So maybe because you guys don't know about pelvic physio, this is some of the stuff I'm going to be talking about, but do any of the words even make sense to you? Do you recognize them? Do you think that you're experiencing any of these things? This is all stuff that pelvic physios treat. So maybe give me a bit of a sense of if you're excited to learn about any of these things, because that will give me a sense of what to chat the most about. So we've got bladder issues, if you're peeing when you laugh, pelvic pain, low back pain, ab separation is really common and popular one. We will be talking about all of these things. So let's start learning. I have my little, I know I'm probably small on your screen, but I have my little pelvic floor model here with me today as well. So we're going to learn about the pelvic floor. Okay, yes, lots of things coming in. All of those things we're going to talk about. So that's great. So your pelvic floor is actually a group of muscles that sit like a bowl within your pelvis. So as you can see here, this is your spine, this is your pubic bone. If I show you the bottom portion, this would be the vaginal canal, urethra, and rectum. This is actually just the superficial level. So like this isn't even all of it. When you take away the first layer, there's a ton of different muscles. They attach into the tailbone, into the spine, into your SI joints, which might be a bit cranky sometimes. So we're going to chat about the main functions of it. But when I learned how many muscles there were, I was like, sorry, come again. I don't know why, but I just thought it was like this like black hole here, but it just like functioned. So I really love teaching about just like how many muscles, how you can control them, and different ways that we can treat some of the symptoms. So it's got 5 main functions, your pelvic floor. It forms that sling, like I said, and it's part of a team. So it doesn't work just in isolation, which we'll get into, but the 5 main functions are sphincteric control. So that means kind of like opening and closing of the canals. So it controls your urethra, your vagina, and your rectum, and it maintains your continence. So if you're ever like leaking a little bit when you laugh or run, that's what's going to be controlling that. Has a sexual function, so through orgasm, blood flow, and it provides that tone for the canals. Sometimes people do experience leaking with orgasm as well, and pelvic physio can actually help improve that a little bit. Stability-wise, it assists the SI joint at the back here. It helps the pubic symphysis, and it helps basically everything that it connects to. It's pretty much like your key core movement main function. So every movement you do, pelvic floor is working. Supports against the gravity of everything, as well as your intra-abdominal pressure. So anytime you laugh, cough, sneeze, you're putting pressure downwards. And that's what helps kind of, the pelvic floor helps combat that a little bit. It also helps with prolapse, as well as supporting all of those organs. So you have a lot of organs in there. You've got these are obviously not like physically in there right now, but you have your bladder, you have your uterus, and you have your rectum, and they're all supposed to stay nice and snug. Sometimes they can move, which we're going to chat about. Not to freak out, we can help with some of those symptoms. The last one is not as commonly known, and it's a sump pump. So it actually helps your venous and lymphatic actual movement through the body. So think of like any type of congested feelings within the pelvis. This would really, pelvic floor movement really helps with that. So it doesn't work in isolation, it works as a unit. So just working the pelvic floor, people always think that pelvic physio is like, okay, I'm gonna go and do like 100 Kegels and that's it. And I'm like, that's like a tiny fraction of what I do, but it's definitely integrated. I want you to think of the pelvic floor as a muscle, because it is. And it's a muscle that both kind of expands and it contracts. So when you talk about Kegels, you're really just talking about that contract portion, and we're not getting enough of the release. So here in this video, you can actually see how there's movement happening, and that movement is your breath. So with each breath that we take, we should actually have movement of our pelvic floor. In almost all of my like in-person internal assessments, that is never really like fully coordinated. So what pelvic physio helps is it coordinates kind of like cogs on a wheel, everything now working together. So the top pink, can you guys see my mouse? Perfect. So the top pink is your actual diaphragm, your breathing diaphragm that's expanding to pressure coming in with each inhale and out with each exhale. The bottom pink is your pelvic floor, and they're supposed to work in tandem together, as well as with these horizontal lines, which represent your ab muscles, and then a couple of muscles in the back that aren't pictured here. So everything should actually be expanding and contracting in unison. So that's really what we're looking for, is really nice symmetrical movement. And so a lot of exercises will be based around the breath, usually in the beginning, and then transferring into movement. And that's just because it kind of taps into your pelvic floor movement without you really having to think about it. And then the picture on the left is just kind of showing when things are not working very well. So think of breath holding when you're picking up your baby, or any of the awkward things that come with that. So like a stroller or like a car seat, literally everything is awkward and like difficult to go around. So if you kind of hold your breath or the pressure goes downwards, it puts a ton of pressure down into the pelvic floor. And if it's not able to respond to that, you can sometimes get a couple of symptoms. This is also another thing that isn't really talked about. Again, everyone thinks of Kegels, and that's more thinking of like contracting. Sometimes when that happens, your pelvic floor muscles can actually get too tight because they're just trying to like do so much work and they're just not able to relax at all. So we really want to make sure that there's balance in this system. It's completely arranged. You can either be completely like overactive where you're just kind of like, oh my gosh, I need to support, I'm never letting go. Signs you might be overactive are you have pain with sex, you have difficulty starting and stopping the flow of urine, you suffer constipation, you might have some pelvic pain. Signs you might be underactive. Oh, actually, you can also leak with overactivity. Signs you're underactive, you might leak urine, you might leak fecal matter, you might feel like you have a little bit of symptoms of heaviness or pressure. So we're just trying to find out where you are on that spectrum and then balance it out. So let's jump into common findings I see postnatal. So what's normal anyways? A lot of changes happen over the 9 months, and then you get a lot of changes afterwards. A lot of times I'll hear like, is something falling out? I've had a lot of people come in and ask if everything looks normal. And it's like hard, like things are different. A lot of change happens in 6 weeks, even 6 months, even a year postnatal. So I would really say like, give some things some time. But really what's not normal is pain, incontinence with leaking, like that should clear up within a week if you suffer any of it. Any type of heaviness or pressure, literally feeling like something is falling out, like those are not things that should be normal, but they're very common. So what is normal and what we're going for, and the grade 3 strength might not make a ton of sense, but basically your pelvic floor strength is graded out of 5. Anything over a 3 means you can basically contract against gravity. A really simple test for this is if you can stop the flow of urine when you're like kind of midstream, but it's the only time that I'm allowing you to do that because it's really good for finding out if your pelvic floor muscles are kind of like responding to you and kind of getting used to it. But it's horrible because it completely messes up your bladder and it's really confusing for the bladder because really you just want it to all empty instead of like stop flow, stop flow. You're able to contract, relax, you're able to hold for 10 seconds, and you're able to go to the bathroom around 5 to 7 times a day. Anything outside of that is a little bit of a flag to come and see a pelvic physio. A lot of common issues after delivery. Let me know if any of you guys, when I like read through some of these, if you're experiencing some of them, again, I'll just be able to kind of like give a bit more information based on that. So incontinence, leaking. I know a couple of you have already said that, yes, you do leak when you laugh, laugh, yes, jump, cry. And then also constipation. I can definitely give some tools for that. Any tailbone pains, that could be like sitting on the tailbone. Any prolapse, again, that's heaviness, pressure, or physically feeling like something is falling out of you. Dysperunia is really just a fancy name for pain with sex. Perineal pain, so anytime that you might like go into a deep squat or you're sitting and you just feel like there's something really uncomfortable. Diastasis, that's going to be the separation of the abs. And then if you had a C-section delivery, just like also a little bit of decreased sensation through the scar, or it's just not as mobile. So any of those kind of ringing any bells for anyone? I know a couple of you have already answered from before, but just if there's like specific ones, I'll chat a little bit more about them. First, I'm going to get into stress urinary incontinence. There's a ton of different types of incontinence. We're going to go over stress, urge, and fecal today. So stress urinary incontinence is found in, Also, I think this is hilarious because I literally typed this into Google and this is what showed up. And I was like, for it to be that common and like give all of these things, I was like, yes, okay, we need to chat about this. This is probably like the #1 thing that I treat. And it's actually the #1 thing that pelvic physio is prescribed for. There's grade A evidence, which means it's like the best evidence possible for you to actually treat these symptoms. So stress urinary incontinence, this is when there's actual like extra stress, like physical stress or pressure put on the pelvic floor. So think like jumping, skipping, HIIT workouts. It can even be as simple as like laughing, coughing, or picking something up, or even changes in position. So from like laying to sitting or something like that. So about 40% of prenatal women experience this, and about 15% of women experience new symptoms postpartum. This is really important because if you're experiencing incontinence prenatal, you're much more likely to experience it postnatal, plus a couple of other symptoms. However, sometimes it takes symptoms as long as 2 to 3 decades following your delivery. So really, I love pelvic physio because it's a bit preventative. We're trying to prevent present as well as future symptoms from popping up. So another thing too is like the delivery method. There is a bit of difference between a vaginal delivery and a cesarean delivery. Cesarean delivery does not mean that you'll never experience pelvic floor symptoms. Actually, I see a couple of other things that we'll chat about. But if you did have assisted devices through your delivery, or if you had a prolonged pushing period, assisted devices would be like forceps or vacuum, anything that just assists the birth, as well as, the prolonged pushing. Those are all going to be a little bit more likely to have some symptoms, which is why I think it's really important to talk about. As well as there's one more I'm forgetting. Oh, a perineal, any type of tearing, especially 3rd and 4th degree tears. So we'll get into that a little bit as well. Urge is a little bit different. So urge is more of that like, oh my gosh, I need to go right now, or I'm going to pee my pants. And sometimes you actually do lose a little bit of urine, and sometimes you don't. So there's wet and there's dry. It can also be behaviorally triggered, which I think is hilarious. I never realized there was a reason for this, but it's like the key in the door phenomenon, it's called. So like, think of when you get home, you put your key in the door and you're like, and now I have to pee. This is more like urge, and it's actually something that you can train, which I love dealing with urge incontinence because sometimes just the education behind it is like super helpful, and it's really, really behavioral. So going back to that 5 to 7 times a day, you should be able to be within those, or even hold every 2 to 3 hours. If you're going way more than that, that is a flag, and that's something that I can help with for sure. It does take some patience though. It's not overnight, unfortunately. Fecal incontinence. So we've come to the brief section of poo of the lecture. We'll talk a little bit about fecal incontinence and a little bit about constipation. A lot of people are always shocked to just find out how much I talk about poop, but it's really important because having really healthy bowel movements are so key for having a healthy pelvic floor. And the reason that this is because if you find yourself really straining, so this is the rectum. If you find yourself straining, it puts a ton of pressure on the pelvic floor, and it can lead to symptoms like prolapse. And it can usually be if you're just like a little bit too tight, where it's actually not letting things go a little bit. Fecal incontinence is on the other spectrum, where you actually don't have enough control to be able to hold back. Typically, mostly seen with 3rd or 4th degree tearing, or if there is a nerve injury. There's lots of different reasons, but sometimes just a little bit of strengthening and awareness can be super helpful for this. Constipation. Anything outside of those like little green stars is a bit of a flag. So if you're 1 or 2, that's more onto the constipation side of things. And then down through the bottom, that's getting into more diarrhea. But what's really interesting is you can actually have diarrhea and constipation at the same time. How I can help with this is we can go through different ways that we, of course, assess and treat the pelvic floor, but also taking a look at your water and fiber intake. I chat a little bit about toilet positioning. You can see this lovely lady in the corner. She's using something called a squatty potty, which is really effective at just like biomechanically positioning your pelvis for a better kind of outlet, as well as different techniques of massage and hands-on work that you can do at home on your own. This is so important to treat because it can really lead to a host of symptoms that just all of a sudden, like 10 years later, I'm treating a lot of like different prolapses. So I think it's better to just get on top of this in the beginning. Hip and low back pain. There's a huge connection to your hip and your low back of your pelvic floor. You can see how it's basically nice and connected through here. It attaches right into your tailbone as well as into the spine. They did a really, really interesting study that I always love to bring up because it was really eye-opening for myself, where they took a lot of people with hip and low back pain, and basically they did a hip and back assessment, and then they did a pelvic floor assessment. And what they found was 84% of the people that identified with low back pain also had a hypertonic pelvic floor. So when we go back to that end of the spectrum, that was more of that kind of like tight, not letting go of anything. That means your muscles, your hips, your joints, they're just not moving as freely as they could be. They also found that this population had dysperunia, which was the pain with sex. And again, that's just due to that tightness. So that's one side where things are just really tight. The other is the pelvic floor can actually mimic hip and low back pain and send referral pain through the trigger points. So I like to teach different types of releases or stretches, or even just learning like what is tight. And then we get through a special individualized program. Tailbone pain, this can either be like from a traumatic portion of the delivery where sometimes people actually have a fracture to it. Or it can be as simple as you're sitting like directly on the tailbone itself, and that can really push it. It's really cool. It moves quite a bit more than you would ever expect. This is not the best model for this, but imagine my finger here is the tailbone. It's able to flex and extend, and sometimes it can get stuck in positions that are not super great, or at least good for like movement. Hands-on mobilizations can be really, really useful, as well as different types of stretching and breathing. The best thing about working with us is that we work as a team. So anytime that I see that maybe you do need a bit of hands-on treatment, I usually refer back to some of our chiros, to our RMTs, to our other physios to see if we can get some of the hands-on treatment that you might need. Because virtual does have its benefits, and of course it has its cons. So, but that's why I like to be able to do more of a team approach. Pelvic organ prolapse is another one I see a lot. So there's different types of prolapse. I have this cute little graphic because I never want you to Google prolapse. It's the most terrifying thing in the world. So just look at the cartoons and then let's leave it at that. So there's different types of prolapse. You can see here that the little hammock is going to be your pelvic floor. And then the yellow is the bladder, the pink is the uterus, and then the brown is the rectum. Most typically, I'll see a cystocele, which is a prolapse of the bladder. Less often, I'll see a uterine prolapse, and then also more often, I'll see a bit of a rectocele. This is different than a rectal prolapse, which is like the intestines coming out the bum. None of these are super pleasant, but I think it's really important to talk about and understand the reality, and also why it's so helpful to go through some of these preventative treatments. So basically, they would just drop into the vaginal canal and be a little bit, so like, for example, if this is the vaginal canal, I can just see them kind of poking out a little bit more. And pretty much what they're doing is responding to pressure. So anytime that there's downward pressure going on these organs, they have nowhere else to go. So they go downwards into the canal. In guys, I usually see this as a hernia because they don't really have the same holes that we do. But it's pretty much all the same thing. It's just being able to control that intra-abdominal pressure. That's a really good question. I just had a question about what is suprapubic pain. Suprapubic pain is pain just above the pubic bone. So sometimes what happens is because everything is being kind of, there's always just like such aggressive words, but basically it's almost like things are dragging downwards. What happens is the muscles and the fascia kind of get pulled with it, and you can get sometimes this discomfort right above the pubic bone. Does that help? Awesome. Okay, no problem. Always let me know, because sometimes there's a little bit more medical terminology than I thought. And then so prolapse, just to finish up a little bit with this, it's perfect. Okay, yes, definitely we can help with that. Basically, we learn how to control against all of the downwards pressure, and we reteach you how to support that and almost bring it upwards. Typically, I'll see either there's almost too much tension and it's really dragging everything down, with a combination of literally every time you breathe or just kind of lift something or cough or laugh, everything's going downwards instead of nice and supported and upwards. So yes, I'm so glad you brought that up. Thank you. So yeah, I typically see this postnatal, probably in like many of the patients that I see. I want you to know it's actually quite common even to have like a grade 1. So sometimes your OB will never like talk about it too much. It's more if you're symptomatic. And I see lots of it also prenatally, or if you've never even had children. So if, like, for example, you can still have prolapse even though you have not had a vaginal delivery. How it happens, just a little bit of just like bearing down during childbirth, during delivery. You've never had like rehab afterwards, so you've never really learned how to coordinate all those muscles back together. But honestly, it's mostly just about the pressure and where it's going. Chronic constipation is also just like a huge one, but we've already chatted about that. Okay, let's talk about sex. So lots of people report pain immediately after, like almost everyone. And again, I want to go back to this kind of like 6-week mark. It is not a fixed date in time. It is very much like maybe. Some people are ready before then, which like kudos to you. And some people take months, even years, and that's totally fine. What I want you to know is that there is help for some of these symptoms that you experience. Because 62%, this is also another study that like is a bit of a generic population. And I think it's also really underreported, but 62% feel pain with sex in the first 3 months postpartum, and then 31% still feel it 6 months postpartum. Really just what I want to highlight is like, there is no ideal timeline, and it's something that we can chat about. It can happen due to sometimes perineal scarring, or like if you had natural tearing, if you had a perineal tear, if you had an episiotomy. It can happen with hormonal changes. So for example, if you are breastfeeding, you can actually have lactational atrophy, which kind of dehydrates the tissue and makes it a little bit stiffer and a little bit more angry and red. And that does really well with like moisturizers, as well as so much more lubrication than you would ever think. But really what is super helpful with this is if you have a scar, we massage the scar and we teach it to desensitize and learn how to expand again. If it's due to more hormonal, we can chat with your doctor and make sure that you can get either a prescription for maybe something if you're comfortable, or a vaginal moisturizer can really help quite a bit. And that's something we can do. So I also want to make sure that you guys know that like, even though it's virtual, you're never like showing me anything. It's always like a little bit of like check-in. I teach you how to do stuff and you come back to me. There's never like anything that happens with pants down on the camera, just so everyone knows. Okay, let's go into diastasis. So this is a really hot topic, I find. And this is the abdominal separation. So many prenatal patients are like, do I have diastasis? I'm like, are you pregnant? And they say, yes, of course. And I'm like, then yes, you have diastasis. It is in 100%. It's literally how your body adapts to the growing baby, which I think is amazing. But for 9 months, your body learned how to expand this way and this way. And then all of a sudden we want in a week for it to learn how to come back like this. That doesn't really happen, but there are ways that we can definitely guide it to kind of reconnect. And it's really about working the deep core system. So this also, all of these are part of our postnatal checkup. I am like screening for all of these things to see what we need to get you back to feeling really, really good. With diastasis, if I could tell you that it could be better in 6 weeks, I would, but it takes a lot longer than that. There's no quick fix. And it's not actually about the separation of the abs. It's more about how much tension you can actually generate within your core. So during your checkup, I always screen for this and we make sure that you can reconnect. And so I want to show you just a little bit of a different graphic here, which I think is really good because everyone is a little bit worried. Sorry, not everyone. A lot of people are sometimes worried about like coning or doming. So when you kind of like lift your head up and you notice a little bit of coning, that's maybe a bit of sign, or it can go the other way, which is called invagination, as it goes inwards, or maybe you just feel a little bit disconnected. But definitely if you have had a kid or you've delivered, no matter the method, reconnecting back to the core is like the #1 thing to do. How we do this is we assess how much it goes. Actually, sorry, this is why I have this here. So for example, we want there to be nice tension that's built within your core. This is not super functional when we're trying to like twist and turn because it's not really quite sure how to create tension and transfer load. And this being your core here. When there's tension, our body understands how to like move and transfer load. So how we assess it is how much tension you can actually generate during like a curl up test, as well as in standing and sitting. And if it's a little bit softer, that's something that we can definitely help with. If it's got really good tension when you bring your head up or when you're doing different functional tasks, amazing. Maybe we just need to coordinate the pelvic floor with it. But I just want it to not be about, okay, if this is my ab here, it's not really how much it's separated. It's just about what's happening through that fascia, through the midline. Oops. So, cesarean delivery. It's not preventative incontinence or prolapse or really any pelvic floor dysfunction that we've chatted about. Typically what I'll see is the pelvic floor actually gets really, really tight because it's a major surgery. And so what happens is they will cut through some of the skin, cut through some of the fascia, and they'll separate through some of the core. So A, it's super important to actually coordinate back those core movements and reconnect. And B, it's important to be able to release the pelvic floor because it got a little bit scared and it's trying to protect you. So it guards you in all of those movements. And typically I'll see just more tension that's kind of being put in there. Postnatally, I actually do really like to support the core and get you to wear some supportive garments just while the core is starting to build back its strength. That doesn't mean that you're like wearing it and that's it. It means we're kind of using it in tandem with some of the core movements that I like to work through. Also, another thing that's not really talked about very much is the importance of scar massage. So you can actually start like as soon as maybe 1 to 2 weeks postnatally, but that would be more like if the scar is here, you would start up here. And it's just learning how to reconnect with the skin and with the tissue. Because again, it's going to be a little bit different. So you might have reduced sensation, you might have increased sensation or sensitivity. We definitely don't want to like move around the scar too much within the first 4 to 6 weeks because the skin needs to heal. But there's lots of things that we can just like gentle stroking just above, breathing exercises that gets the core moving and kind of does indirect movement of the scar. So many things that can really just help guide that movement within your postpartum journey. Why this is so important is because 5 to 10 years post C-sections, I see so many scars and they don't move. So what I mean by that is your skin, if you take even your skin on your forearm and it moves all around, it moves up and down, side to side, circles, you can pinch and you can lift it. That's how your scar should feel. And if it doesn't feel like that, not to worry. It doesn't matter when you start, but we can actually start to make it feel a little bit more mobile. And why that's so important is because if you imagine your scar as almost like saran wrap and it's just tense here and not moving, well, everywhere else is going to either compensate or it's just always going to feel like it's a bit stiff and stuck. So once you actually free that motion up, oh my goodness, the changes that I see are so cool. And it's just something as simple as working on the scar. Another thing I love working with, I'm a runner myself, and I recently rehabbed myself from a abdominal surgery. And with that, I can't believe it's just like not a given. But with running specifically, we'll get into the impact, but with running, what I wanted to bring up is they did some studies on runners that were prenatal and postnatal. And what they found was that there were a ton of changes that happened in the trunk and in the pelvic motion during pregnancy running that were not back to baseline 6 to 7 weeks after delivery. I'll chat a little bit in the next slide, but pretty much if you're 6 weeks postnatal, you should not be running anyways, first of all. It's at least 12 weeks. But they also found that basically at a 6-month follow-up, some of the gait changes had improved, but there was still a ton of excessive pelvis motion. So what I mean by that is instead of the motion being kind of like more sagittal, forwards, backwards, it was a lot of side to side motion, which doesn't propel you forwards very much. And it's really, really hard on your hips. So think of like those cranky SI joints, think even of back pain, think of hip pain, pretty much any pain. If this is not moving as well as it could, you're going to get something that just gets a little bit cranky. So it's definitely something I love working on. And so this is more return to impact. So think of your HIIT workouts that you've done, jumping, running. Honestly, even if it's not like workout specific, think about running after your kid or like how active children are. I want you to be just like prepared for anything. You're prepared for if your kid just like comes and jumps on you and you got to catch them, or literally anything in the day. Returning to impact is most recommended at 3 to 6 months postpartum. So this isn't really something that people talk about and it's like, cool, 6 weeks, get back to what you were doing before. And as a pelvic physio, I'm like, no, please, please, please. There's so many other things, because probably during your prenatal period, you weren't maybe as active as you were like when you never were pregnant. Sorry, no one cares. And that's a long amount of time where your body is slowly deconditioning, in the sense of you're not jumping as much, running as much, lifting as much. So there's a strict time-based plan that I run you through, and it incorporates a lot of different things and gets you back to impact activity, but it definitely does not start with impact activity. And basically what's on here is the checklist. So are you even appropriate to start? And some of you might be much further postnatal than 6 months even. But if you can't do some of these, then maybe it's a good idea to just kind of revisit the basics and then work your way back up. So what I'm looking for, and I can actually test some of this virtually just by you kind of telling me what's going on, is at least a minimum grade 3 out of a 5 strength. Again, that just means that you can contract against gravity. If your pelvic floor cannot contract against gravity, and then you're running and you're adding all this impact, you're most likely going to experience some symptom at some point. And usually that is prolapse that I'll see, or leakage. The other thing I need you to be able to do is about 8 to 12 reps of a 6 to 8 second hold. Honestly, if you guys even want to try some of this stuff now, it's a really good indication of like, okay, can I do this? A 60-second hold of like very low level, around 30 to 50% of a contraction. Walking 30 minutes without symptoms. Again, that means heaviness, pressure, leakage, pelvic pain. Can you balance on one leg for 10 seconds? Can you single leg squat on one side 10 times with good form? Can you jog on the spot for a minute? Can you single leg hop, forward bound, running lunge? So there's so many things that we look at, right? It's, again, not just about the pelvic floor. And this is a nice segue into what I assess. So yes, the virtual is a little bit different, but again, there's so much that goes into it. And I just love it because it's really putting everything in your court. I am guiding you through the process, but you're really needing to like kind of be consistent with some of the stuff that we're working on. So it starts with a history and some questionnaires. The questionnaires are lengthy, I apologize, but every piece of information is really important, I find. I look at your breathing as well as your sternal angle and your rib cage. So that means the angle here. It needs to be around 90 degrees instead of flat or too close. So I take a look at that. I take a look at your posture, both static as well as movement. So you can see I take a look at some functional movements. It also depends on your goals and like really what you want to get out of the session with me, because I'll make it as specific to that as possible. I take a look at your diastasis if you have any, as well as a core assessment, lower body, external vaginal exam. You can do internal, and honestly, if I think that that's appropriate for you, I will send you. That's no problem. I just want you to get better. How aware you are of your pelvic floor, how strong your contraction is. Can you even relax it after a contraction? It's endurance. And then we go over some homework and we talk about your treatment plan. What I use as treatments are lots of different tools. I love just learning about different things that help. And again, I want it to be something that's realistic and doable for you. We go through strength, we go through mobility, there can be stretches, there can be exercises, there can be self-massage, there can be breathing. There's lots of different things I can use. I try and make it fun so that you actually do the stuff. And when in doubt, honestly, I just want you to make sure that if anything came up today, please get it checked out. Of course, I'm here as a resource. But if we don't click, I also think that the connection with your therapist is really important too. So if you do need someone else, no problem. I don't take anything personally. Pelvic Health Solutions has a list of providers, and Herman and Wallace is more stateside, but I think it's good to know. And that's pretty much it. If you did want to book with me, I offer 15-minute consults just to go over and make sure it's a good fit and see what the treatment plan can look like. You can book online at corthacare.com and you just hit the book now button and it will take you to the list of providers. I'm under pelvic physio, and then you can book based on that. That's pretty much it. That was so long. I'm so sorry.
Fantastic. We really appreciate having you. I'll just give you a couple of minutes here. If anybody has any questions, now would be a great time to ask those on.
Yeah, any questions at all? There's never TMI. Literally, that's always what I say. People are like, I don't know if this is TMI. I'm like, no, nothing is. But also, if you want it to be more private, I'm happy to do the 15-minute consults. Those are a great chance to just go over any further questions that you might have, and specifically what treatment can look like for you, because it's really different for everyone. There's no cookie cutter program. I'm not doing the same thing with every person, and it's really, really based on what your goals, expectations, and of course, symptoms are.
Can you see the questions here?
I don't see any right now.
Someone has anonymously asked if you have any experience working with endometriosis and pelvic health.
Sorry, you said someone's experiencing endometriosis. Is that what you said?
Yeah, and asking how you would treat that with pelvic health.
Ah, yes. Okay, perfect. So that's a really good question. That's not as like postnatal specific, so I just didn't include it in here, but it's definitely something that that pelvic physios can treat. So with endometriosis, there's no real cure, unfortunately, at this time. They do a lot of more surgical based types of treatments to actually like excise the lesions. However, with pelvic physio, what we would be focusing on is managing your symptoms. So a lot of the times the symptoms can be abdominal based in the sense of like gastrointestinal. So sometimes there's a lot of like belly bloating, there's a lot of fatigue, there's aching around the pelvis, there's cramping. So what we try and do is we tackle those symptoms and really just figure out what your main symptoms are first. And then we go through more down regulation. So what that means is we take the pelvis that's really usually quite tight, and I try and teach you how to release it through different techniques, such as breathing, some mindfulness, some stretches, and just learning how to basically open the pelvis a bit more. Because sometimes what they found is that when this gets really tight, that sump pump that we talked about way back in the beginning, it's not letting everything flow as nicely. And that can cause a buildup, pelvic congestion buildup, and that can sometimes lead to increased symptoms. So what I found with my work is that we can sometimes decrease the symptoms and decrease the intensity of flare-ups and the amount of flare-ups, but it will not necessarily take everything away, unfortunately. And then there's also hands-on treatment that we can do. I teach some visceral mobilization techniques that you do on yourself, or you can do acupuncture with our team. There's really good evidence with acupuncture that can help relieve some of the cramping and symptoms. Those would be different ways that I tackle that. Any others? I can't hear you for some reason, Jillian, sorry. Oh, are your services, oh, I can see this one. Are your services covered through benefit plans? Yes, that's the best part. So pelvic physio is actually covered under physiotherapy. And I believe Cortha Care does direct billing as well. So we usually try and get all of your information and make it as seamless as possible for you. So the initial assessment is 45 minutes long. It's $115. And then follow-ups are 30 minutes at $95. And typically I will see someone, now again, take into account this ranges for every person, but typically for like incontinence, it's around like 6 to 8 sessions over 12 to 16 weeks. For core, it's 16 weeks plus, but maybe there's just like more spaced out appointments. And then for anything else, yeah, that's usually typically what I'll do is around 6 to 8 sessions, but spread apart. And then if you need more or less, fantastic.
I think that's all the questions for today.
Perfect. Well, thank you so much for being here. Are you able to work? I love multitasking. It can sometimes be a little bit difficult depending on the issue. However, a lot of them are usually connected. So if there's a pelvic floor symptom and another type of symptom, usually treating either one or both together at the same time is tackling the same like root issue. So yes, short answer.
Well, thank you so much for joining us.
Yeah.
The time of your day as well, Jessica. And like I said, so Jessica usually works with us 12 to 5 on Mondays. She's very busy with her Ironman training, so we use her as best as we can. But if you have any questions, like she said, she does virtual appointments for 15 minutes. You can call, you can video chat, whatever you're most comfortable with.
Awesome. Yeah. Thanks so much.